Hello, this is a brief introduction to the elbow exam workshop for the May 4th, 2018 University of Toronto Primary Care Sports Medicine Conference Workshop. Once again, with a basic musculoskeletal examination, where we break it down, as always, into inspection, palpation, range of motion, and as well as special tests and referred pain. And this is no different. So when we take a look at the elbow, this is actually with the patient either standing or sitting, and they have their arm winged out to the side, so you're actually getting a posterior view of the elbow. You can also take a look, obviously, from the different sides, but once again, you're looking at the contours, both cavities on either side of the olecranon here, either medially over the ulnar side of the elbow or laterally in between the olecranon and the lateral epicondyle to see if there's any loss of that contour. And then also taking a look at the arm itself, so both the anterior arm over the biceps and posterior arm over the triceps, as well as the medial and lateral forearm. Also looking for bony prominence over the lateral medial epicondyle of the humerus, the olecranon, and assessing the radiocapitellar joint as well. As always, looking for evidence of color changes, most commonly in around the olecranon, sometimes associated with olecranon bursitis, cellulitis, or septic bursitis. And then bruising with respect to ligamentous or muscle tear injuries, such as that are associated with dislocations, subluxations, and also just acute muscular injuries of the elbow. When we talk about palpation, once again, we're taking a look to see if there's any warmth in the elbow, checking to see if there's any infusion. We can take a look in the junction between the humerus and the olecranon through this space here, but we can also take a look at the posterior and palpating the posterior aspect of the radiocapitellar joint to see if there's any fullness or tenderness in that area. And then also looking for superficial swelling, such as over the olecranon once again, and over the epicondyles, both medially and laterally. We can also assess for tendon tenderness, both with the extensor and flexor common tendon origins, as well as biceps tendon and the triceps tendon posteriorly, and also with using range of motion to check for any snapping of either tendon structure or nerve structure. Most commonly, a triceps tendon or ulnar nerve would be the commonest reasons for snapping of the elbow. When we talk about range of motion of the elbow, there's four main ranges of motion. There's obviously flexion and extension of the elbow, but there's also pronation and supination, which happens mostly as a result of the structure of the radiocapitellar joint. Once again, this is a view of the posterior elbow. We can see the medial epicondyle here, lateral epicondyle here. You just see the outline of the radiocapitellar. Obviously, this would extend out this way as well. This is the ulna down here. This is the olecranon. And when we're talking about pronation and supination, it's occurring as a result of the radius rotating around the ulna. When we talk about referred pain, we always have to be careful with the elbow, as there are other causes of lateral elbow pain other than lateral epicondylitis or tennis elbow. One of the things from a referred pain perspective is referred nerve pain. So you can consider both upper limb neural tension tests as well as Sperling's tests and neurological tests to make sure that there's no evidence of any kind of neurological pathology causing that lateral elbow pain. We talk about special tests. There's a number of different special tests for the elbow. Picture here on the right depicts a hook test. Essentially, this is the patient's arm on the right, and this is the forearm, this is lateral, and this is medial. And you essentially take your finger and you hook the biceps noted by the purple outline here, and you see if that's essentially taut. If it is, that indicates an intact biceps. However, if it's not taut and person has pain or weakness with supination, that's an indication of a distal biceps tear. There's a lift-off test, which essentially, if you take a look at the videos, you take a look at the posterior aspect of the patient's elbow as they lift off a chair, and you can, in fact, see the radius disengage from the capitellum. And that's something you see with posterolateral instability of the elbow. For radial tunnel syndrome, you can do direct palpation of lateral elbow. So once again, this is the outside of the arm and forearm, and this is where we would typically have lateral epicondylitis tenderness. The radial nerve comes down anterior and down into this area here where you have the radial tunnel, which is essentially outlined by the supinator. One branch of the nerve goes superficial, the other one goes deep. If you palpate over that area, that'll often reproduce pain in somebody with radial tunnel syndrome, but you can also get them to resist extension of their third or middle digit against resistance with their forearm and pronation and the wrist inflection, and they'll often have weakness in that position with radial tunnel syndrome. And then finally, with the ulnar collateral ligament, which is the medial ligament, stabilizing ligament of the elbow, you can do a valgus or a milk test to assess for stability of that ligament.